So now I'd like to introduce our speaker for this morning. We're very pleased to have Dr. Puneeta Sharma. She is the Director of Palliative Care at the Valley Hospital, and she is going to lead us in this discussion today. Welcome, Dr. Sharma. Thank you for joining us.
Thank you so much, Susan, for having me here. It's a pleasure to be able to talk to everyone virtually. Although I would have wished we would have met in person, but we're getting there slowly and slowly. So hopefully, we will be able to see each other in person. Hopefully soon, one day. So thank you everyone for being here. And today I wanted to talk to you about what is palliative care and what is advanced care planning. So just to give you a little bit of a background as to what was the need for the field, there are patients who have serious illnesses, and there was research that was done on patients who were suffering with serious illnesses as to what their wants were. So there was an article that was published in JAMA. This is one of the old articles, which is sort of like one of the pioneer articles, which led to thinking about the need for development of the field as well. So when patients with serious illnesses were interviewed, their wants or needs were focused on a couple of things. First and foremost, they wanted to make sure that their symptoms are controlled. Often patients towards the trajectory of their illness in the last phases, they were extremely symptomatic, but they were not getting adequate symptom control. Patients did not want to inappropriately prolong the dying process. They wanted to make sure that they had a sense of control and strengthen their relationship with their loved ones. And last but not the least, they did not want to be a burden on their families. And what were they getting? Again, there was another landmark study called as the support trial, and which outlined the gap between what patients wanted and what they were actually getting. So, this study involved a huge database of the patients, and about half of those patients died within 6 months of entry into the study. Only about half of the physicians knew about their patients' preferences. Approximately half of the orders for do not resuscitation were written only in the last 2 days. Close to about a third of the patients spent their last days in an intensive care unit away from their family. And about half of those patients, who died in the hospital, they reported that their symptoms, particularly pain, was not controlled at least half the time. So this study actually really indicated that there was a gap between what patients actually wanted and what they were getting. How could this look instead? How could we do better? What if we knew what mattered to each and every individual who was seeking care? What would this look like if all the information that the patients and the families needed to make decisions for themselves or for their loved ones was adequately available to them? What if everyone who was involved in the care of the patient, whether it was the family members or the caregivers or the clinical team, they were all on the same page? What if we could do a better job in ensuring that our patients' symptoms were controlled? What if we were able to provide support throughout the trajectory of illness? What if we were able to manage expectations and alert patients and families and caregivers about what sort of crises to expect and how to deal with those crises? And how about if we were able to provide goal concordant care to our patients and families every single time? So this is what exactly palliative care does. Palliative care is a specialized medical care for people who are living with serious illnesses. It focuses on providing symptomatic relief, no matter what the diagnosis. The goal is eventually to improve quality of life, not just for the patient, but for the family and the caregivers as well. So who can provide palliative care? As an individual who is experiencing a serious illness, they have a multifaceted environment in which there are multiple needs and not just physical symptoms. They have social concerns, they have physical concerns. So in order to be able to meet those needs, we do need a multidisciplinary team to be able to provide that support. So palliative care is provided by a team of doctors, nurses, and other specialists, depending upon the situation of the patient, who work with the patient's other doctors as well as the patients and families and provide an extra layer of support. This kind of care is appropriate at any age and at any stage of a serious illness and can be provided while an individual is seeking curative treatment for their illness. So in short, it's an extra layer of support above the medical care that the patients are getting. And it's a paradigm shift in healthcare delivery because, what was happening in the beginning was we were focusing on an individual organ, we were focusing on an individual disease, but palliative care encompasses a whole person philosophy, a well-rounded, multidisciplinary, holistic approach to managing patients' concerns, needs, and not only just but their caregivers and folks who are involved in taking care of those individuals. So, what are some of the goals of palliative care? Our goal is to improve care by using a multidisciplinary and a holistic approach, and improve population health by relieving symptoms in the course of an advanced illness, and guide patients and families in what are the goals of care and having early conversations based on their preferences, culture, and spirituality, and eventually, helping decreasing burnout for our patients and families, because it's not easy to be involved in providing care to these individuals who are suffering with serious illnesses. What's the care model of palliative care? Often what happens is palliative care is confused with hospice. So I just wanted to give you a visual of what palliative care looks like and when it's appropriate. So if you look at the picture here, on the horizontal layer, is the trajectory of the illness, which starts off with the presentation, and then followed by the diagnosis, followed by the trajectory of the illness evolving between acute, chronic, and life-threatening, and eventually death. So in the initial part of the illness, when an individual is presenting with a disease and is diagnosed, the focus is more towards curative therapy, where initially the amount of curative therapy that's provided is higher and higher, but as the disease trajectory progresses further, the amount of available curative therapy that's available, that may become limited. And earlier, palliative therapy used to be sought once the curative therapies had been exhausted. But that care model is changing now. So if you look at it from the previous, from this slide, palliative therapy would begin after all the curative therapy had been exhausted, versus the change in the provision of care now is that palliative care is provided alongside the curative or the restorative therapy. As an individual moves along the trajectory of the illness, as the amount of curative or restorative interventions become low and low, palliative interventions continue to increase and increase. And it's only towards the last 6 months of life that hospice is appropriate. So palliative care can be started right from the beginning, and it can continue throughout the trajectory of an individual's illness, as opposed to hospice, which is only for 6 months, last 6 months of life. So what are some of the things that we take care of when palliative care is being provided? So you look at the physical aspects of care, making sure that an individual's symptoms are dealt with. You address the psychological and the psychiatric aspects of care. You look at who is necessary to be involved in the patient's care team to be able to provide the answers that an individual may seek. You look at the cultural aspects of care. You look at spiritual, religious, and existential aspects of care. You look at ethical and legal aspects of care in terms of, who's making the decisions if in case an individual is not able to provide or make decisions for themselves. You look at the social aspects of care and, of course, end of life care. And at the center of all of this is the patient and the family. The overall goal is improve value for the patients and their caregivers, improve population health and caregiver health. So just to visualize the difference between palliative care is the broader field under which hospice is an intervention which is available for individuals whose life expectancy is expected to be around 6 months or less. So what are some of the interventions that palliative care does? Palliative care helps you establish a personalized care plan along with your core team in making sure that there is treatment and relief from symptoms. Make sure that your plan of care is coordinated. Make sure that you have a support and a safety net, skillful communication, and all of that is timely. Now, advanced care planning, this is an important part of palliative care. So what is advanced care planning? Advanced care planning is defined as information on types of life-sustaining treatments that's available out there, deciding on type of treatment one would want if they were to experience a life-limiting illness, ensuring that an individual's personal values are shared with their loved ones. It involves choosing an individual or a group of individuals who may be responsible for helping an individual make decisions for themselves when they are no longer, when a patient is no longer able to decide for themselves. Advanced care planning also may be recorded in the form of official documents like a healthcare proxy or a POLST form or power of attorney forms that you may have often come across. So who is appropriate for advanced care planning? So advanced care planning can be instituted at the annual wellness visit. It does not mean that you have to be, totally sick in the hospital, experiencing a life-threatening illness. Again, the depth of the advanced care planning will depend upon where in the trajectory of an illness an individual is. So if it is somebody like, otherwise healthy, no other issues, ensuring that you have an appointed healthcare proxy is helpful, so that just in case there is a situation where an individual ends up with a life-threatening or a sudden life-limiting illness, then in that case at least there is somebody who knows about that individual's wishes. So it's important to consider advanced care planning at the annual wellness visit. Of course, if somebody has an end-stage chronic illness, it would be very appropriate for them to have advanced care planning. If there are changes in your health, if there are changes in your wishes, or individuals who experience a sudden event or are at risk of repeated episodes, it's important for them to be able to tell their loved ones or their decision makers as to what they would want in case they were not able to make decisions for themselves. Eventually, it's about you. It's about what matters to you the most, especially at a time when you may not have as much control over your illness, when you may lose the ability to voice out your wishes. So it's important to have that conversation early enough with an individual or a group of individuals who you trust, so that they can carry out your voice, they can carry out your wishes should you not be in a position to make decisions for yourself. Who can perform advanced care planning? So your physicians or non-physician practitioners like nurse practitioners or PAs can help you perform advanced care planning. What are some of the forms that are available out to you? Again, you don't have to go into the details of this form, but this is one of the examples of what an advanced directive looks like. So, it talks about choosing a healthcare representative. So you can outline somebody who is, who you trust with decision making for your health, and you could choose alternate representatives. You could give them specific directions as to what you would want or not want, and where should these copies be sent. Importantly, this document has to be signed by an individual who is doing the advanced directive. So for example, if I'm formulating my advanced directive, I have to be able to sign it, and it has to be either notarized or it has to be witnessed by two witnesses. So often I've encountered situations where a patient for whom the advanced directives or advanced care planning is being considered, those individuals are not in a position to make decisions, And, family members or caregivers or loved ones would say, we can do the advanced directives. So unfortunately, at that time, you cannot do the advanced directive because the advanced directive has to be signed by the individual themselves first before it can be implemented. So if an individual is not able to make decisions for themselves, then they cannot sign the advanced directive. So another form of an advanced directive is a POLST. Now, POLST is a much more deeper or a much more detailed version of an advanced care planning. If you would notice, the advanced directive outlines a healthcare proxy or a healthcare representative and some specific directions, versus POLST is a deeper dive into exactly the course that needs to be undertaken should an individual not be doing well. So POLST stands for Practitioner Orders for Life-Sustaining Treatment. This is an official state form. This is for individuals with advanced illnesses. It is divided into various parts. If you see, it has rows A, B, C, D, E, and F. The row A talks about, what are the goals of care? What would this individual want? Row B tells you about what are the medical interventions that this individual would have wanted for themselves. The POLST can actually be completed by the individual themselves, or it can be completed by the healthcare proxy or the decision maker or the surrogate who is involved in decision making for the patient. So as far as the medical interventions are concerned, there are three kinds. So the broad aspect is that it's divided into three parts: full treatment, limited treatment, and symptom treatment only. Full treatment means keep going, no limitations, no restrictions, keep doing all the tests or whatever therapy that can be, offered, keep continuing that. Limited treatment means, folks are able to voice out what they would want to undergo or what they would not want to undergo. So, for example, if somebody says that, it's okay for me to take, for example, if you have somebody who has cancer and they say, well, I will take the chemotherapy, but I will not take surgery and I will not do hemodialysis. That means you are opting for some things and you're not opting for other things. Symptom treatment only is when you do not want to pursue, aggressive interventions, but you say, just keep me comfortable, just treat my symptoms and don't do, invasive measures. Symptom treatment is more or less like a hospice like situation where you're focusing only on the symptoms. Again, you may or may not qualify for hospice at that level, but you are choosing for yourself that you're only going to pursue symptom management only and not further aggressive or invasive intervention. This form also allows you to record what are your preferences about artificially administered fluids and nutrition. What happens is when you have an advanced illness, often as other symptoms are progressing, and when the illness is so advanced, your ability to eat will also be affected. So if that's the situation, what are your preferences? Would you want to be, fed via feeding tubes, artificial nutrition, or would you rather allow nature to take its course, make sure that you have good mouth and oral care, and let nature take its course whenever the time comes? Again, you can record your choices over here. Row D of the form talks about what are your preferences about CPR and about ventilators or the breathing tubes and the machines. You can choose whether you want it or you don't want it. Then part E talks about that, if you are unable to make decisions for yourself, then is your designated decision maker or the surrogate allowed to make changes to this form, yes or no? So you can record it onto the form. And then part F is the signature, where it needs, signature by you. And it also needs to be co-signed by your either physician or the nurse practitioner or the PA. And below row F is your surrogate's information, just in case they need to be contacted. On the right-hand side of the slide is the back side of the form, and it gives certain directions for how the POLST needs to be completed. So POLST is a portable document. It is valid wherever you are, whether you're in the hospital or in your doctor's office, or if you are in a rehab facility, wherever you are living. So it does not You do not need to enter, other orders or complete other forms if you have a POLST already there. So it kind of like speaks the, has a universal language where, this is understood by various healthcare professionals that may be involved at various facilities. The beauty of this is that this is a portable order, so it's valid no matter where you are. Also, I want to bring to your attention that this is not something that this is written in gold. So let's say, you were early on in the trajectory of your illness, you could record a certain set of choices or preferences that you would want for yourself. And let's say if along the course of the, illness, if situations change or your preferences changed or wishes changed, or your decisions change, then this can be modified. So it's a evolving or a work in progress document. And at the end of the day, it is all about what matters to you and what you decide. Whichever way you decide, if you want to pursue, that's the way to go. If you feel strongly about not wanting to go on to certain invasive measures, having a discussion with your healthcare professional and making those appropriate choices. Again, the idea of all of this is for you to be in charge of your health, and not only that, ensuring that your wishes and voices are heard even when you are not able to participate in decision making. So the ultimate goal is for a good life, a very good life, to the very end. And I just wanted to remind everyone that in April, we have the National Healthcare Decisions Day that's coming up, and below the date is a link to the Conversation Project, which can help you, get started to have the conversations with your loved ones. It is not easy to have these conversations, but imagine, if your loved ones were faced with a situation where they had no idea of what you wanted, how would that be for them? So the biggest, one of the biggest gifts that you can give to them is ensuring that you tell them what matters to you, what are your preferences, what would you want should things not go the way that you wanted them to go, or should you not be in a position to make decisions for yourself. So that's the end of my slideshow, and open to any questions.
Okay, thank you so much. Somebody had a question, does POLST work out of state?
So depends upon, you will have to speak to the healthcare professionals over there. So for example, New York has an equivalent which is called as a MOLST, Medical Orders for Life-Sustaining Treatment, and New Jersey has a POLST. But if you have a document like this, when you discuss it with the healthcare professionals in another state, they should be able to guide you whether you need to complete another form, but at least it gives them a framework as to what an individual's wishes would be.
Okay, great. Another question is, so at what age can an individual sign a POLST? I know healthcare directive. Is there any specifics regarding that?
There's no age limit to signing a POLST. So I would say that POLST is for individuals who have serious illnesses, right? So for example, if I have no serious medical illness, and if I have otherwise I'm healthy, or if my condition is controlled, I would start off with the healthcare directive or an advanced care or a healthcare proxy, and make sure that I have appointed somebody as my decision maker should I encounter a sudden illness like that. But let's say now I am diagnosed with a chronic illness, and that chronic illness is becoming severe and severe, then at that point in time a POLST would be appropriate. So there's no age criteria. It depends upon the trajectory of the illness or the seriousness of the illness that you have.
Okay, thank you.
So it's like the different dosages, if you may. So POLST is a much more deeper, discussion of what your preferences are. And actually, at this point in time, I would also like to point out one more one more difference between an advanced directive and a POLST is advanced directives or healthcare proxy documents or power of attorney documents. They may outline what your preferences are. So it's a statement of preferences, but POLST is the actual execution of those preferences. So often, let's say if I'm doing okay, and I said, okay, I need to appoint a decision maker. So appointed, let's say I appointed Susan as my decision maker, and I said, Susan, so here's my preferences, and this is what I would want, or this is what I would not want should I suffer a serious illness. All of that can be recorded in in the healthcare proxy or an advanced directive document. But now let's say I have, let's say, I'm developing a metastatic cancer, or I got a disabling, stroke or something like that. Now would be the time to consider, a POLST form where I can actually say, Susan, this is what I want, knowing what I know about the illness so far, this is what I want, or this is what I, don't want. So it's a much more deeper conversation.
Right, right. Thank you. So someone asked about should a copy of your POLST or healthcare directive be given to your local hospital and or physician, or how would you distribute those documents?
Absolutely, it is so important for your healthcare provider to be involved in all these discussions, because it's about your health, it's about your medical decisions. So if you have done an advanced directive, please ensure that a copy is provided to your healthcare provider. And when you go and visit them again during, for example, if you qualify for annual wellness visit, you can provide them a copy at that point in time, or regardless of the annual wellness visit. Whenever you go and visit them, you can give them the copy of your advanced directives so that they know who's the, what would be your preferences, or who would be your decision maker should you not be able to uh, voice out your voice out voice out your choices. And another thing that I would like to point out here is that it's not only important to initiate this, but it's also important to revisit this at certain intervals. It may be a good idea to reconsider your choices annually, just to make sure that your preferences or wishes have not changed. Or if, God forbid, if you had you were diagnosed with a serious illness, or if there was a change in life event or something like that. Often we come across situations when when advanced directives have been done, like decades ago, and they were not revisited, and now you are in a situation where an individual is totally towards the towards the end of life, and in between, the caregivers are wondering now how to proceed. So it's important to revisit those, and it's important to tell your caregivers or your loved ones or your surrogates, whosoever is your appointee, to let them know what your wishes are.
Along those same lines, if someone is at home and an ambulance is called, maybe someone is gravely ill but breaks an arm, and EMTs have to. Should a POLST be on the refrigerator, accessible? Because there's been situations where people have invented when they didn't want, those types of things. Yeah.
Right, exactly. And these should be, often, again, we come across situations where these kind of like documents exist, but they're lying in lockers and things like that. And, they've not been accessed. So having them readily available, having them easily reachable would certainly help medical professionals to ensure that the care that is being provided is accordant with your wishes.
Absolutely. Okay, good. Do you know anything about insurance covering palliative care services at this time?
So what I would say that yes, insurances do cover palliative care services, but I would still say that please inquire specifically with your insurance, because you certainly do not want to be in a situation where it's not covered and you are charged for it. So it would be a good idea to just ensure with your insurance that it's covered.
Great. And if somebody wanted to start palliative care, they're in the community, how would they go about doing that, Doctor?
So there's a couple of ways that they can do it. First and foremost would be having a discussion with their primary care physician, who's involved in their care, or patients can, self-refer themselves. So we do have palliative care services offered, in the office setting as well. So they can call there, or we have a, palliative care department number. So they can call Valley's palliative care department number, and we can certainly look into whether they qualify for palliative care services. But speak to your physicians.
And if in the hospital, can they, someone's in the hospital, can they just reach out to someone from your team? If someone's in the hospital wants to start palliative care?
So, well, if they're in the hospital, they can let the staff know that they want to speak to palliative care, and we'll be more than happy to be there. Speak to your doctors who are taking care of you,
Mhm.
and they will be able to call us.
Yeah, it sounds like it's good to have these forms, even if you're going to the hospital and the hospitals have it in the past, to make sure you have the forms with you. It's really important.
Right.
That was,
And actually, so for example, I'll give you a scenario. So let's say, you had a POLST done with your physician in the office, right? So let's say you had an advanced directive or a POLST done with your physician in the office, and now you come to the hospital. Make sure that you get that you bring your POLST with you. Situations may change, right? So choices may change, preferences may change. So if there are any changes that are made to the POLST form, make sure that a copy is given back to, with the updated changes, it's given back to the involved folks, including your caregivers or surrogate decision makers, whosoever is responsible for making choices for you.
great. Yeah, communication, right?
Right.
All
That's the
communication.
key. That's the key.
Absolutely. Wonderful. So yeah, thank you so much, Dr. Sharma. This was so informative, and it's wonderful to, just be able to learn more about this. It's so important.